In this presentation, we'll be learning about Angle's class 2 malocclusion. Sir Edward Angle, father of modern orthodontics, classified malocclusion based on the relationship of maxillary first and mandibular first permanent molars. In cases where the distobuccal cusp of the first maxillary permanent molar coincides with the central groove of the mandibular first permanent molar, it is known as class 2 malocclusion. Class 2 malocclusion again is divided into other types of categories, which is class 2 division 1 malocclusion, class 2 division 2 malocclusion, and class 2 subdivision malocclusion. Each of this type of malocclusion has different traits and is differed based on its features. We'll be talking about it in detail in the further slides. For class 2 division 1 malocclusion, according to British Standard Classification, the lower incisors edges lie posterior to the cingulum plateau of the upper incisors. There is an increase in overjet and the upper central incisors are usually proclined. There are various reasons for class 2 division 1 malocclusion to manifest. If they are skeletal patterns, habits, soft tissues, dental factors. In skeletal patterns, class 2 malocclusion, class 2 division 1 malocclusion can be seen in cases where there is mandibular deficiency, that is, the mandible is retruded or backwardly placed. In class 1 skeletal pattern, that is, in which there is an underlying class 1 skeletal pattern, but however, in the dental features, the molar relationship is in a class 2 position. Or the third scenario in which there is a maxillary excess, that is, either the maxilla is forwardly positioned or is larger in size. So in all of these cases, the common feature that is seen is that there is an increase in overjet. In this picture, we can appreciate that there is an increase in overjet, however, the bite is open. That is, that there is a negative bite. Talking about habits and soft tissues. So another reason for this type of malocclusion to occur is an abnormal oral habit. For example, in cases where there is circumoral muscular activity, rolling the lip, lower lip behind the upper incisors, moving the tongue forward between the incisors, or combination of all of these above. So either the patient has abnormal muscle activity, or the patient has lip biting, patient has tongue thrusting, patient does thumb sucking. Any of these kind of activity leads to a lot of abnormalities in the occlusion. For example, narrowing of maxillary arch, proclined upper incisors, retroclined lower incisors. So all of these usually lead to an imbalance between the buccinator muscle and the tongue forces. So there is an imbalance in the buccinator mechanism. Buccinator muscle is one of the circumoral muscles of the oral cavity, because of which what happens is that the patient later presents with an incompetent lip. So this is a case in which the proclination of upper incisors and retroclination of lower incisors with a class 2 molar relationship. Now talking about dental factors. So dental features such as tooth length, tooth size, arch length discrepancies, because of which there is an exacerbation of overjet. So what it means is that the mesiodistal widths of all the teeth that are present in an arch does not coincide with the arch length of the arch, because of which there are various malocclusions that the patient can present with. This is a patient presenting with class 2 division 1 malocclusion. Extraordinarily, we can appreciate that there is lip incompetency. When we say lip incompetency, we basically mean that the upper and lower lip do not touch in rest position or do not coincide during rest position. Here we can see that the incisors are proclined, and in the lateral profile of the patient, we can see that the patient has a convex profile because of maxillary excess. In the intraoral features, we see that there is a deep bite. We see that there is spacing that is seen in the anterior region. This shows that there is a tooth material arch length discrepancy as well. The patient's molar relationship is class 2 on one side and end on the other side. We will classify such a patient under the category of class 2 division 1 malocclusion. Class 2 division 2 malocclusion. According to British Standards classification, the lower incisor edges lie posterior to the cingulum plateau of the upper incisors. The upper central incisors are retroclined because of high lower lip line. The overjet is usually minimal or maybe increased. So how is this different in to class 2 division 1 malocclusion? Is that basically the upper incisors are retroclined, and this again has various etiologies: skeletal pattern, soft tissues, dental factors. Skeletal pattern of such patients usually present with mild class 2 skeletal pattern, or it can also be associated with a patient who has an underlying class 1 or class 3 skeletal relationship. In such patients, usually the vertical dimension is reduced since there is no occlusal stop during the occlusion for the lower incisors. There is a tendency of increased bite. The patient mostly presents with a deep bite. Soft tissue of the patients might present with a short upper lip, or the patient has a excess of lower lip. There is active muscular activity. The upper lip line is generally higher, and the lower lip line is also positioned more on the upper central incisors. Dental factors in patients presenting with class 2 division 2 malocclusion, usually crowding is seen, which later worsens. Since the upper incisors are retroclined, they provide less space for the other teeth to accommodate themselves in the arch. This is a patient presenting with class 2 division 2 malocclusion. In the extraoral features, we can see that the patient again presents with a potentially incompetent lip. This can be due to the overlapping canines, and as you can see that the incisors are retroclined. In this patient, again, you can appreciate a convex profile, and we can see a maxillary excess with retruded mandible. Talking about the intraoral features of the same patient, there is a deep bite, retroclined upper incisors, overlapping laterals and canines. The patient presents with a class 2 molar relationship on the right side and a class 2 to end on kind of molar relationship on the left side. Another thing to check for is the canine relationship. In these cases, we can appreciate that the canine relationship again is end on. Talking about class 2 subdivision malocclusion. So these are the kinds of malocclusion in which molar relationship of class 2 is presented on one side and class 1 molar relationship is presented on the other side. Again, in subdivision kind of malocclusion, it can be either class 2 division 1 subdivision or class 2 division 2 subdivision. So we base this upon the incisor inclination. If the incisors are retroclined, they would fall under the class 2 division 2 category, or if the incisors are proclined, they would stand under the class 2 division 1 subdivision. Now talking about the treatment of patients who are who present with class 2 malocclusion. The management of class 2 skeletal pattern can be done by 3 ways: growth modification, orthodontic camouflage, and surgical correction. So choosing any of the treatment depends upon various factors. One of the major factor is whether the patient is in the growing stage or the growth has completed. So the growth modification procedures that can be done are in which basically we can stimulate and enhance the mandibular growth. So this is achieved by using functional appliances. It can be either fixed or removable. So there are 3 types of fixed appliances: flexible, semi-rigid, or hybrid, and rigid appliances. In flexible kind of appliances, examples would be Jasper jumper or Churro jumper. Semi-rigid hybrid appliances, example would be Eureka spring. In rigid type of appliances, Herbst appliances was widely used. In removable functional appliances, The various examples are activator, bionator, Frankel, twin block. So any or each of these appliances has a different kind of fabrication and different kind of uses depending upon individual case they are selected. Orthodontic camouflage. So orthodontic camouflage means that the jaw discrepancy is no longer apparent. That is, the patient does have an underlying skeletal problem. However, we mask it with changing the dentoalveolar relationship of the teeth. Three patterns of tooth movement can be used to correct class 2 malocclusion: non-extraction treatment with class 2 elastics, retraction of maxillary incisors into a premolar extraction space, distal movement of the upper teeth. So this can be achieved by extractions of the upper incisors. So the three patterns of tooth movement can be used to correct class 2 occlusion. So it can be divided into extraction and non-extraction therapy. In non-extraction treatment, we can use it along with class 2 elastics. In extraction treatment, retraction of maxillary incisors into a premolar extraction space and distal movement of the upper teeth. So in this, usually upper four, that is the first premolars in the maxillary arch, and second premolars in the mandibular arch can be extracted, or all four premolars, all four first permanent premolars can be extracted, depending upon the crowding the patient presents with. In non-growing patients, the approach, the permanent correction would be obtained by orthognathic surgery. So there are various types of surgeries that have been given in the literature. Bilateral sagittal split osteotomy is used for mandibular advancement or retrusion. In this case, we can see that bilateral split sagittal osteotomy, in which basically cuts are made on the body, in the body of the mandible, and the mandible is taken forward and then fixation is done. Sliding osteotomy, in which to advance the chin, cuts are made and fixation is done. Thank you.